National Rehabilitation Week, the third week of every September, reminds us of the unique and valuable role rehabilitation services play in restoring patient quality of life and helping people live to their fullest potential. A majority of Americans will require at least one rehabilitation service at some point in their lives, and nearly 50 million Americans have a disability. Because the actual and potential need for quality rehabilitation is so great, it's vital that our system ensures access to high-quality physical therapy, occupational therapy, and speech-language pathology, including for patients who may also require hospital-level care. And two innovative health organizations in New Jersey are helping to lead the way forward. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, senior writer with AHA. What happens when an acute care hospital and a post-acute care facility join forces? How do patients benefit when they pool resources and share responsibility for an episode of care? Does this approach save money and result in better outcomes? Christian Health Care Center is a short-term rehabilitation center in New Jersey. It's partnering with Valley Health System, which also has locations around the Garden State, to bring a new multi-organizational approach to rehabilitative care. With me today to discuss how it's all working out are Douglas Struyk, President and CEO, Christian Health Care Center, and Dr. Robert Brenner, President of Clinical Integration for Valley Health System. Rob and Doug, thank you both for coming on Advancing Health today. If you could just give a brief overview of each of your organizations, what you're about, and maybe Dr. Brenner, you can start, and Doug, you can follow up.
So Valley Health System is a regional health system in northern New Jersey. It was started in 1951, has a long history in Bergen County area. So it's comprised of basically four entities. The Valley Hospital, which is approximately 450 licensed beds and about 1,200 medical staff. The Valley Medical Group is 400 providers, 50 specialties, and approximately 70 locations. The Valley Home Care has a census of approximately 1,200 per day, so it's fairly large. And we also have a clinically integrated network with about 600 physicians that spans through Bergen County. Just as a point of interest, we are involved in a lot of service lines with high complexity of our patients in cardiovascular, oncology, women's and children's, as well as neurosciences.
Yes, Christian Healthcare Center is a regional provider in northern New Jersey located in three separate locations. We are a 110-year-old not-for-profit provider offering senior living, short-term rehab, and mental health services. In addition to the skilled nursing facility area we'll be talking about today where we're providing rehab services, we also have a full senior living continuum including assisted living, independent senior housing, adult day services, and then on the mental health side we have a psychiatric hospital and a continuum of outpatient and partial mental health services as well.
So how did this partnership come about between your organizations, and what was the motivation for each organization for electing to do this?
Obviously, we have geographic proximity, and so there was a high rate of transfer of our patients to Christian Health. A lot of our patients demanded to go there or requested to go there. And over time, I think that we found in terms of our cultures and values that we were very much aligned, which solidified the relationship. As value-based care came into play, the relationship became more, I would say, formal in terms of our meeting times and some of the strategies that we imparted to really have continuous care, a high level of continuity, and a working relationship. The motivation really, I think, on both organizations, and I'm going to have Doug speak to this, is seamless care and coordination.
Yes, I would agree with what Rob has just indicated. I've been with this organization for 30 years, and from the first day I've been here, Valley Hospital and Valley Health System has always been a very valued partner, one that we have done a lot of work jointly together with residents and patients that we serve, a lot of transfer back and forth. So when the opportunity came to move into this value environment, it was just a natural progression of our joint interest in always wanting more than anything to do what's best for our patients, and that kind of leads into the motivation as well.
Who are the different types of rehabilitation patients, especially higher acuity, who are benefiting from the partnership right now?
We could go through the specific types of patients, but overall, I think that where we are helping patients is in that transition of care. That's where most of the errors occur in healthcare in general. There's communication gaps, throughout, and that's where things fall through the cracks. So I think the benefit to our patients is really all of our different types of patients, because we're communicating so tightly that we have reduced harms and errors.
And I would add that in that approach of really having every patient that we jointly work with benefiting from this process, it's given us an opportunity to see how patients with different type of clinical or other unique aspects give us an opportunity to develop approaches that are geared toward that. There's been enough volume to enable us to develop some synergies and some practices that we've been able to hone over time, and the trust in the communication and the focus that we have on quality has really been seamless and benefited across the continuum.
Has working together in a seamless way required a lot of retraining of faculty and staff at both organizations?
I don't think that it's required retraining. It just required a different vision of what are we responsible for, and that all entities are actually responsible for that transition, the receiving organization as well as the one that's transferring the patient. So I think what it did is really heighten our awareness to that we have to really do this well and make sure that our patients are, everything is communicated to the transferring organization. That's what's the most important thing.
And all of that is built on a really strong foundation of trust. That was probably the most important ingredient that was embedded in this whole process. And with that shared trust and also the alignment of our values, as Rob mentioned earlier, that gave us the opportunity to perhaps train with respect to maybe certain unique procedures or processes that we might put in place to foster the communication that we want to happen and to deliver the outcomes to the patients that we're caring for. But again, that long history of working together already provided us with an opportunity and history of talking the same language in many respects. So since we knew each other very well, it was a natural foundation springboard upon which to move toward higher value.
And what tangible benefits have you been able to track so far, such as fewer readmissions or better oversight of an entire episode of care? What do you see bearing fruit so far?
This is the exciting part, is that the relationship has shown steady improvements in whether it's quality metrics or cost of care. So specifically, we've decreased our readmissions in 2015 from 15% to 7%. So that's more than half of a reduction. And we decreased errors with the soft handoff, and that's, more anecdotal. We've also had a length of stay that's dropped in the post-acute in Christian Health from 27.8 in 2015 to 14.6, which I think is just, very admirable that we've been able to do that as a team.
And what's been even more gratifying for us as a part of that, the data that Rob just shared, is that we've been able to maintain a very high level of satisfaction in those we serve. We're both very data-rich and data-driven organizations, and so in looking at the triple aim, if you will, and plus one when you bring in employee engagement, but the level of satisfaction has been high, as well as being able to bring down and change those results that Rob mentioned.
That's impressive improvement. Congratulations. What specific ingredients do you think make the partnership work? For example, joint case management or HIT connectivity, anything along those lines?
Yeah, there's a host of things that our teams have done, mostly at the level of our clinical teams, but obviously, we have executive oversight to this. But access to the medical records, so our medical records can be accessed at Christian Healthcare. We have regular meetings. We have a big monthly meeting to coordinate our programs. We also have weekly utilization review meetings and joint case management. In addition, Valley has some population health navigators that work very closely with Christian Healthcare. We also share our data, and that's part of our agreement and our collaboration so that we each can compare because, as you know, the data can be, different from different perspectives and depending upon where you get it from and how you evaluate it. So we share data and try to reconcile at our meetings. And we also have a universal transfer form that's been augmented to include additional data that's important for the patient transfer, and we have a handoff tool that we use as well. So those are some of the ingredients to this success.
And I will add that those ingredients, again, fall back on that foundation of quality and communication and trust, and they flow so naturally from there. In addition to the navigator that Rob mentioned, we shared an advanced practice nurse back in the early days, which was a great initial tool to help us kind of bridge that clinical communication. And with respect to warm handoffs, it's not only from the acute care setting to ourselves, but it's then from ourselves to home care as well. And so that we're really actively looking at that 90-day period, this early portion of which rests with the acute care hospital and stay here, but then what's happening beyond. The goals are aligned, and that really helps us to pull all that together. We're also working on developing some care pathways and protocols for certain specific diagnoses, and that's going to further hone our ability to guide patients through the continuum.
I'm curious which clinical or other leaders in each of your organizations is sort of tasked with facilitating this connection. I mean, is it something that is just the highest management in each organization are dealing with each other, or does it go much further down than that?
So, no, it really extends from the leadership at the top in the executive C-suite all the way through the organization. So I'm involved as a president. We also have a director of our clinically integrated network involved, as well as our director of population health, and then we have population health navigators. We have people that are running the bundles. So all of these people are involved throughout the organization. I think that it's part of our strategy in terms of value-based care to have these kind of relationships, and we've been very fortunate to have this relationship with Christian Healthcare.
And I would share that description as well, that with myself and my colleague, our Chief Operating Officer, to work with our clinical leadership, whether that's the physiatrist who's our VP of Medical Affairs or the internist who is our full-time medical director, the nursing leadership, right down through transitional planners and MDS and frontline nurses who are engaged in deliberation and discussion and evaluation and assessment of patients, social services, all the way through, so that the entire team is focused in a team-based way in delivering care and understanding how outcomes matter and understanding and having a role in the data that we're able to review and look to improve.
Has your partnership produced cost savings so far for the overall patient episode?
So one thing I can comment on is that the decreased average length of stay has resulted in average payment down from 2015, where it was $14,600 to $9,200 currently. So yes, it has resulted in a decrease in cost of care.
And I think that the natural question that flows from us on that side is, that decrease in cost represents a reduction in revenue on our side. And what we have seen as a mission-driven organization is that though the cost per patient has dropped, we're now able, with that shorter length of stay, to serve that many more patients and deliver that much more value to a greater number of individuals from our community. So it's been a win-win all around.
I think it's commendable that an organization is willing to say, I'm going to, for the sake of patient care and producing value, I'm going to accept and embrace this type of payment model and this strategy. So it's been great. There's one other thing that I wanted to mention, and that was the other entity agreement that you may be interested in. That's a template from CMS on how you relate to healthcare organizations outside of your own. And it kind of gives you guidelines on how to set up that relationship. And it doesn't necessarily have to be monetary, although it can. And our relationship with Christian Healthcare is not. But in that agreement, it's basically stating how we're going to collaborate, and basically we outline most of those things in this conversation. But we only choose a set number of those organizations that meet the standards that we believe are the highest quality, the highest level of coordination, as well as the lowest cost of care or the appropriate cost of care.
And picking up on that further, that for many who are listening to this who are providers like ourselves, they're facing the beginning of PDPM and what all that means and what that represents for providers in terms of reimbursement and the economic outcomes. And this whole value approach that we've been working on and been very successful in has really positioned us to be well ahead of that PDPM transition and to really be aligned with its goals already. So we're excited to see how our ability to be that much more prepared and in line with PDPM will better serve the system and process as well.
You sort of anticipated my final question there, which was just that what lessons can you pass on to other organizations that may be considering a similar partnership between hospitals and post-acute care facilities? What advice or experience would you share at this point?
Clear expectations that you agree upon and clear goals.
And there has to be a real strong alignment of that intangible relationship, that the level of trust that we have had with each other from the start and from before the start was so essential to enabling us to build upon this, because we are very much no longer, as the system had us years ago, islands to ourselves. We are very integrated and working very closely and relying on each other to be a part of this process. And that underlying trust that we had was so essential to the success that we've had in the way we've brought quality in, and we've been able to communicate about quality outcomes in a real honest and transparent manner.
The heart of our trust is that we're both entities, both organizations are really out for the same thing, and that is to make sure that our patients are doing well. And so knowing that that's really where we're at and that's our goal, we have a very strong level of trust.
The team approach to rehabilitative care being forged by Christian Health Care Center and Valley Health System appear so far to check every meaningful box: savings, improved care, better outcomes, and happier patients. This has been Advancing Health, a podcast from the American Hospital Association. Thanks for listening.